power versus speed, mechanical advantage versus disadvantage. If I talk about a first-class lever system, it is a mechanical advantage, and I need the power. Remember, we talked about holding your head up. So anytime the fulcrum is the atlantoaxial joint. So even nodding yes is a first-class lever system because it's the power to hold our heads up. It is a power lever mechanical advantage first-class system. Nodding yes. Second class would be standing on your tiptoes. So if I'm on my tiptoes, I think I said in the class, looking over a fence or trying to see something, that is a second class lever system, also power. I need the power to hold the weight of my body, and it is a mechanical advantage. Third class lever systems are speed levers. They operate at a mechanical disadvantage. That's what most of our muscles are. Shoveling snow, hitting a golf ball, hitting a baseball, bench pressing, bicep curls, leg raises, all of those are mechanical disadvantage because they want the speed, not necessarily the power. And that's third class lever systems. Know the fascial arrangements for various muscles. That was one of our lectures and one of the slides. I must have deleted all of those. I thought I kept them for my 4 o'clock class. So the fascial arrangements. By the way, I'm sorry I was a few minutes late. I apologize. So here are the fascial arrangements. Circular is around most orifices. So the oculi, orbicularis oculi around the eye, orbicularis oris around the mouth, the anal, the urethra, any orifice has typically circular fascioles. Then we said pectoralis was convergent. The deltoids are multipinnate. The rectus femoris is bipinnate. And the biceps brachii are fusiform. Then we talked about this one being unipinnate. The sartorius has parallel fascioles. Thanks, Karen. Okay, here we go. So that's the fascial arrangements. I can't think of what that question is. Be able to determine if a muscle is an agonist, antagonist, synergist, or fixator. Remember, a muscle can be either one of those depending on what the prime action is. However, I'll key in on fixator. Our rotator cuff muscles are stabilizers and fixators. They fix the head of the humerus inside the shallow glenoid cavity. So they are both fixators and stabilizers. Know the process of inhalation, exhalation, and the muscles involved. Remember, inhalation, external intercostals, exhalation, internal intercostals, and both of these inhale and exhale with the help of the diaphragm. So for inhalation, I have the external intercostals contracting with the help of the diaphragm to expand the chest cavity for inhalation. For exhalation, the internal intercostals contract, collapsing the chest for exhalation. And these muscles work in conjunction with the diaphragm. Be able to determine the muscles injured during an accident by knowing the muscle locations in the body. Only the muscles we have identified in the course. And what came to mind when I read that is a hernia. Your rectus abdominis is that muscle that comes down the front. Sometimes it is perforated, i.e. we get a hernia. I didn't teach that, but I think that question is on there, but I know you would figure it out because it's the organs protruding through that muscle. A sprain versus a strain. I talked about being deployed with a battle buddy. She tore her Achilles tendon. and they shipped her back to the US. It takes, you told me on this second exam, which is true, takes tendons and ligaments a long time to heal because they do not have a direct blood supply like bones and muscles. Their blood supply is from a perichondrium, like a girdle surrounding them. But if she tore her Achilles tendon, she had a strain. The T in strain is for a tendon. And then other injuries, if it's a ligament, would be a sprain. No one be able to determine if an action is sensory input, motor output, or integration. In class, during my afternoon class, the national notification system for mobile phones had an alert just testing the system, and all the phones went off. It was kind of loud. I knew it was coming, but I still jumped. Is that sensory, motor, or integration? Sensory input, sensory input, motor output, or integration?
Sensory?
Very good, Richard. It's sensory, because I heard it. I heard it. So hearing it ring is sensory. But when I flinched, that was the motor output. That was, or I picked it up to silence it. That's the motor output. So very good. The hearing it ring is sensory input. I think when I flinched, I got us all off. So here's that one: sensory input, motor output. Know the types of neural circuits. Converging. Remember, that's like thinking about Christmas or Thanksgiving. Several things come to mind, but they all remind me of Christmas or Thanksgiving. Several inputs, one output. The thought of the holiday, the turkey, the stuffing, the whatever it is, the snow, the pine smell, Christmas. So it's lots of inputs, one output. Diverging is the type of neural circuit we use most often. You have one input, one axon that's transmitting through a lot of axons to arrive at the destination. So one to many is diverging. Many to one is converging. Reverberating, sleep, wake, sleepwalk, just walking, sleep, wake up, any repetitive cycle, reverberating. And then parallel after discharge are those exacting procedures like surgery, or in a particular profession, nursing, PT, etc. Given a specific situation, there are a specific set of steps that you must take in a specific order. And I used math. You have to know which one to do first: parenthetical, non-parenthetical, addition, subtraction, multiplication, in order to get the right answer. So those are exacting, parallel after discharge. Know that neurotransmitters can be inhibitory or excitatory, and know an example. Cardiac, acetylcholine is inhibitory in cardiac muscles. Acetylcholine is excitatory in skeletal muscle. Know the process of muscle contraction and to be able to answer various questions. Also know what occurs when a muscle is at rest, what occurs when a muscle is contracted. For example, when a muscle is at rest, can myosin bind? And the answer is if that muscle is at rest, can myosin bind?
No.
You're correct, Richard. No. We have to have calcium bind to troponin so that troponin can change shape and rotate tropomyosin out of the way. So on that question, it gives you a whole, in fact, oh, I'm seeing the answers. Good. And many to one was indeed converging, Grace. I wanted to see. Terminal cisterns. So a question on the exam, something like this. Here are the, I called it sarcoplasmic reticulum, which is here. And this is a Quizlet. But the sarcoplasmic reticulum, you also have those terminal cisterns, which are here in the sarcoplasmic reticulum, which is where the calcium is stored. That's where your calcium is stored in the terminal cisterns or the sarcoplasmic reticulum. So when this muscle, this sarcomere, because we contract sarcomere to sarcomere to sarcomere. So when this muscle gets ready to contract, these terminal cisterns or sarcoplasmic reticulum release the calcium so that it can bind to troponin, change shape, and rotate tropomyosin out of the way. So if there's a question and it says, what is occurring in this muscle, which of the following is true regarding this muscle, and you've got this picture or this picture or this picture. Remember, some of your exams, you're gonna have things that don't really matter, not germane or pertinent to the answer. So it may be this picture, but there'll be a scenario that says that muscle is in a state of contraction. Which of the following is or is not true? Well, if that muscle is in a state of contraction, the calcium is where? It's in the cytosol. It has been released from the sarcoplasmic reticulum, the terminal cisterns. So just remember, if the muscle is contracted, the calcium has been released and it's in the cytosol. If the muscle is not contracted, the calcium is stored in the sarcoplasmic reticulum or the terminal cisterns. I need to get a thumbs up. Y'all got that? Want me to repeat it?
Yes, please.
So if a muscle is contracted, terminal cisterns are the regions within a muscle. They store the calcium. I called it the sarcoplasmic reticulum. It's also the terminal cisterns. Terminal cisterns, an overview, they are basically enlarged portions of the sarcoplasmic reticulum where the intercellular calcium is stored. I was looking for that Quizlet question, and I'm not going to find it only because I'm looking for it. But Quizlet, it was there. The terminal cisterns store the calcium. And here's the operative word, release it. And this is saying when an action potential courses down, but and release it when contraction occurs. So the terminal cisterns store the calcium. If that muscle is contracting, the calcium is not in the terminal cisterns or the sarcoplasmic reticulum. It has been released so it can bind to the troponin, resulting in a change in shape and rotating the tropomyosin out of the way. So how does the terminal and the T-tubule interact in a muscle contraction? The calcium, and there it is again, the calcium has to be released to bind to troponin, resulting in troponin changing shape and rotating tropomyosin out of the way so that you can get that muscle contraction. Remember, I said early on, we're going to learn that you need calcium, not just for strong bones and teeth. You need it for muscle contraction, and you need it in the nerves to release the neurotransmitter, in this case, acetylcholine. So that's what this, know the process of muscle contraction, be able to answer various questions. Myosin cannot bind if that muscle is at rest. And it makes sense. If the muscle is at rest, it's not contracted, so calcium has not been released, so it can make the myosin binding sites visible to get contraction. So calcium is in the terminal cisterns, in the sarcoplasmic reticulum, if the muscle is at rest. If the muscle is contracted, calcium has been released, and it is bound to troponin. And this is another one about the joint actions. Flex and extend, we talked about. Supinate is drinking from a bowl of soup, and our hands are in the supine position, supination position, and in anatomical position. Pronation is just the opposite of supination. And remember, supination, drinking from a bowl of soup. The opposition movement is when you can put each of the other fingers to the thumb. Retraction and protraction are opposite movements. Protraction is pouting. You eject the mandible out. The muscle that does it is the mentalis. That's coming up later. That's protraction. Retraction is retracting your mandible. The actions permitted by very common muscles. Remember, retracting your scapula like a soldier at attention. But I don't have good posture. If we had good posture, we actually sit like this. So those rhomboids are also involved in posture. We said the serratus anterior for boxing. The latissimus is very pronounced in swimmers. The main muscle for chewing is the masseter for mastication. So if I bite down on an ice cube or a popsicle or a Jolly Rancher, it's that masseter muscle that's doing it. Rhomboids. I think those are the main ones we talked about. How do skeletal muscles increase in strength? We recruit additional muscle fibers. Remember I said if I'm bench pressing, each muscle fiber has its own axon and artery and vein. So if I'm only bench pressing 10, there's no need to activate all of my muscles to control, all of my muscle fibers to contract. But if I'm bench pressing 100, then I'm going to need more muscle fibers than I did when I bench pressed 10. So to increase in muscle strength, we, in the textbook and in my notes, I put, we recruit additional muscle fibers. The longest muscle in the body is the sartorius. I've already mentioned the muscle for chewing. The main muscle is the masseter for mastication chewing. Structural and functional classification of joints. Structure, which is anatomy, is complementary to function, which is physiology. The structural classification of joints is the structure. Is it fibrous, cartilaginous, or synovial? That is the structure. It is either fibrous, cartilaginous, or synovial. The functional classification is how does it function? It moves not at all, which is synarthrotic, moves a little, which is amphiarthrotic, or our synovial joints are freely movable, and that is diarthrotic. Know the types of arthritis discussed in the section on joints. Lyme's disease is not a form of arthritis. It's really being bitten or having a tick burrow in, transmitting bacteria, and all we need is an antibody, but it does affect the joints. However, the 3 types of arthritis we discussed are osteoarthritis. By age 85, half of the people have it. It's just normal wear and tear of the joints. Rheumatoid arthritis is autoimmune, causes disfiguring. Some of the joints kind of tend to fuse, and it is an autoimmune disease, rheumatoid arthritis. Then we have gouty arthritis, where uric acid crystals deposit in the joints, typically in the fingers or the great toe. Know the action of neurotransmitters. Neurotransmitters jump the synaptic cleft like acetylcholine, and they bind to the acetylcholine binding site on the neurolema. And we talked about the biogenic amines will need a specific level before we refer because they are involved in mental health. And then we talked about a few others, but we'll get into more detail as we go into the nervous system. But the action is that they bind, and that allows us to go from electrical down the nerve, cross that gap, which the chemical does, the neurotransmitter, and then it goes back to electrical in the muscle because sodium will rush in. And how are neurotransmitters removed? I mentioned several times, I want you to know that because we have to get rid of them or the muscle stays contracted. So after acetylcholine is released and binds and initiates contraction, then that acetylcholine will be broken down, or it will go back into the axon terminal, or it just diffuses away from the site so that that muscle doesn't stay contracted with the presence of acetylcholine. So it diffuses away from the site, reuptake into the axon terminal, or it's broken down by an enzyme. Know the structure and function of a nerve cell. The dendrites receive the input. You have your cell body, and then the impulse goes out the axon. The axon has axon terminals and synaptic clefts or terminal boutons. Those terminal boutons release the neurotransmitter. And I think that may be a short answer. Know the joints we discussed, the structure of each joint. The knee is a modified hinge. It is synovial. The hip is a ball and socket. It is synovial. The elbow is a hinge. It is synovial. And in the knee, the fibula is not a part of the knee joint. The knee joint is the tibia with the fibula. The tibia with the femur on top, and then you've got your patella. And remember, there were 3 joints in the knee. We have the femur, the femoral patellar joint, the femur and the patella. And then for the femur and the tibia, there was the lateral and medial femoral tibular joint. But the fibula is not involved in the knee at all. It is non-weight bearing. Know the facial expressions relative to joint action. Shrugging your shoulders is elevate, depress. And then we've got the facial expressions coming up. Be able to differentiate between the 3 types of muscle. I asked you to just kind of peruse. Oh, I did the fascials. Peruse the muscles. So I just look at a few. I am sure you would know that this bottom one is cardiac, the top one is skeletal, and this middle one is smooth. That is this one, I think. But looking at this one, skeletal, cardiac, and smooth. So just be able to tell them apart. I look at a few just to be sure you can tell them apart.
Would that question be more of a slide or words?
No, it's going to be the pictures, and you're going to match it with what type of muscle it is.
Okay, thank you.
What is rigor mortis? Rigor mortis is rigor after death. So 3 to 4 hours after death, which is why I think Kiara was saying, you know, they tell the family, you've got 3 hours, then we have to take the body. 3 to 4 hours after death, rigor sets in, and it peaks at 12 hours, 12 to 24 hours. After that, the muscles start releasing because the protein is being broken down. So rigor mortis occurs because we need ATP for the myosin head to bind, and we need ATP for the myosin head to detach. And once we die, we're no longer making ATP, so that myosin head stays bound. and the rigor begins to set in 3 to 4 hours and then will eventually peak. But the protein gets broken down, so eventually the heads will detach. Know the facial expression and the muscles to perform the facial expressions. We're coming up on that. Name at least 3 synovial joints, and don't forget the ands on the exam. State the type of joint based on the shape of the articular surface, which can govern joint movement. Note this is not structure and classifications with the 6 types. We have the plane where the carpals glide over each other. We have the pivot. You can pivot the ulna over radius or radius over ulna, or we can pivot the atlas on the axial. That's the second one. The third one is a ball and socket joint, and that's your hip and your shoulder. And the fourth one is the hinge. That would be the elbow or the knee modified hinge. And the fifth and sixth, the condylar here in the interphalanges. And then between metacarpal and carpal, metacarpal number 1 and the carpal trapezium, that is a saddle joint. So know the name at least 3 synovial joints and state the type of joint. So I just did that. The knee, the hinge, ball and socket, condylar, etc. Be able to match specific facial expression with the correct muscle. Again, I'll just put a box over the muscle, and you will, I think it's matching. But don't quote me, but I'm pretty sure it's matching. It will just say match the muscle to the correct facial expression. And there are always more answers than you need. So zygomatic for smiling, orbicularis oris, oral, for pucker up. The mentalis is the muscle, and that's for pouting. Don't forget the joint action is protraction. This is the platysma for tense neck. The frontal belly of the epicranius or the frontalis for wrinkled forehead. The orbicularis oculi for blinking, and then the corrugator supercilii for angry eyebrows. Questions on the lecture? We good?
Yes, I'm good.
Okay, thanks. Okay, here's the lab. Choose a muscle that represents the image. Classically, we just said that one. Remember, lecture is reinforced by lab, or lab reinforces lecture. So I just talked about the frontalis causing wrinkled forehead. And it says choose the muscle, although I thought that was a fill in the blank. But, it could be multiple choice. But anyway, it's the frontalis for wrinkled forehead. Know the part of the rotator cuff that's most frequently injured and why? That is straight off the lab. I pointed it out. It is the tendons, most specifically the supraspinatus tendon, because we constantly are working above our heads or lifting the shoulder. But it is the tendons that are most often injured in that rotator cuff, hence physical therapy to rebuild the muscle tautness. Know the neuroglia and PNS and CNS, and PNS is the satellite, which are the most numerous, and the Schwann are for myelination. In the CNS, the astrocytes are the most numerous, and the oligodendrocytes are for myelination. And then the 2 that are in the CNS, because there are 4 total, the other 2 are the microglial, defensive in nature, and the ependymal, circulating the cerebrospinal fluid. From gross to microscopic or macroscopic to microscopic, and it was the same thing here. From gross to microscopic, we have the muscle, and the epimysium is around the entire muscle. Then we have the perimysium around a group of muscle fascioles. And then we have the endomysium around an individual fiber. So that question is rewritten for the lecture exam. From gross to microscopic, name the parts of the muscle. Muscle is gross, or macroscopic. You have the muscle, then you have the fascioles, and then you have the muscle fiber. Name the quad muscles. You have the rectus femoris and 3 vastus, vastus lateralis, medialis, and intermedius. Name the hamstring muscles. You have 3. You have the biceps femoris and 2 semis, semitendinosus, semimembranosus. Name the rotator cuff muscles. There are 4. You have the teres minor, supraspinatus, infraspinatus, and then the subscapularis. Know that the rhomboid muscles retract the scapula. They are diamond shaped and they pull the shoulder blades together like a soldier at attention. So therefore, they also play a role in posture. Remember, I already mentioned they retract the scapula like a soldier at attention. But if we're sitting up straight, we're practically that way anyway. So it is with good posture, they are also involved in posture. And that's what that is saying. The rhomboids play a role in posture. Know that if you bite down on an object, chew, masticate an object, the masseter muscle is the main muscle. I named the other muscles involved in chewing, but the masseter is the main muscle. Know that the erector spinae is that group of 3 muscles that is most susceptible to injury during heavy lifting, and that's what we see a lot in the ER with back injuries. Know that facial muscles, they are unique. And I think it was my morning class that asked the question, oh, I don't see a tendon, especially on the circular fascioles, like the lips and the eyes. Where does the muscle insert? The facial muscles are unique in that they insert onto skin or other muscles. And I actually mentioned that the dimples are actually how the muscles insert onto each other, and that dimple is kind of a little gap in there. So the facial muscles insert onto skin and other muscles, not bone. Know the joint movement for side leg lifts. I just said that. That is abduction. Know the joint movement for bicep curls. If it's joint angle decrease, it's flexion. If it's joint angle increase, it's extension, because we do both for the curls. Know the muscle and joint movement for pouting. The muscle is the mentalis. The joint movement is protraction. So the joint movement is protraction. The muscle is mentalis. Why are injections given in muscle rather than subcutaneously? Injections are given in muscle. That's in the lab also. In muscle because the muscles hold a larger volume than subcutaneously, and the muscles have a greater blood supply, so they enter the bloodstream quicker. Matching in lab 16, part A, page 2. And Grace, no, only the insertions that I told you about in class. And I think there were very few to none. So do we need to know all the words? No. So for the lab, here is this one, which said know the parts of a neuron and their action. So again, the dendrites, the axon, and the terminal boutons or synaptic end bulbs. The neuroglia, the 4 in the CNS and the 2 in the PNS. And it said part A, page 231. So here is part A, page 230. Is it page 231? Yes, part A. Myelinates the axons in the peripheral neurons. That will be the Schwann cells. Phagocytic in the brain and spinal cord is the microglia. Insulating material around axons is the myelin. Receive stimuli from sensory receptors or other neurons, that's your dendrites. Chemical messenger released from the synaptic end bulbs, that's your neurotransmitter. Long cellular processes that transmits an action potential, that's my axon. Ciliated cells that circulate the cerebrospinal fluid are the ependymal cells. Unmyelinated areas between the Schwann cells are nodes of Ranvier. Helps to form the blood-brain barrier. Those are going to be tight junctions, but the 4 microglia in the CNS are astrocytes, microglial, which are defensive in nature, ependymal, which circulate the CSF, and oligodendrocytes, which myelinate. So that leaves the astrocytes. And it is indeed the astrocytes that help to form the blood-brain barrier, those tight junctions. Myelinates axons in the brain and spinal cord, the oligodendrocytes. Contains a nucleus and most of the organelles, that's your cell body. Releases the neurotransmitter into the synaptic cleft. Those are my synaptic end bulbs. And helps repair injury to the peripheral neurons. We'll get more of that as we get deeper into the nervous system. But it is the neurolema or the membrane in a nerve cell. Remember, we said that you've got all the neurons you're going to have for life. They're amitotic. The only exception is that if a peripheral neuron gets damaged, as long as the cell body is intact, we can have Röhlerian degeneration where the membrane, the neurolema, repairs itself. And this test, Lolly, is just like the others. True, false, matching, fill in the blank, short answer. The rest of this, I wanted to call your attention to this part. But of course, I think there's a question about the local anesthetic. So while we're here, be sure to know that the way they work as an anesthetic is that they block the ligand-gated channels or the sodium channels or the ion channels. The bottom line is sodium never rushes in to generate an action potential, which is how the body communicates with us to let us know we're feeling pain, etc. So the sodium never rushes in. The nerves just don't communicate with us. The anesthetics block that nerve transmission. And this was only lab 16. Don't forget, it's 13, 14, 15, and 16 on the exam. The muscles that cause tense neck is the platysma. I just showed you the myogram. I showed you the single twitch, wave summation, unfused tetanus, and fused tetanus. Another type of movement that occurs when using the inner thigh machine in the gym, and that would be ADD, adduction, and the muscles are adductors. Another type of joints, hinge, ball, and socket. We went through those, the 6 types of synovial joints, and we talked about the structural classification. The ball and socket being synovial, and we gave types of those. Define circumduction, which is movement in a 360 cone of air. Dorsiflexion is pointing your toes toward your tibia. And know how local anesthetics work. I just showed you on the exam. On the lab. And I think this may be a true-false question, so just read it. Be able to critically apply muscle contraction to determine the actions that are occurring in the muscle. Again, I'm foot stomping. Calcium is stored in the terminal cisterns of the sarcoplasmic reticulum. If the muscle is not contracting. If the muscle is contracting, the calcium has been released into the cytosol, so it can go and bind to troponin. The T tubules are those areas where they allow deep invagination so that that stimulus can cause the exocytosis or the release of the calcium from the terminal cisterns. These are the muscles that you need to know. And let me just show you. They're not that many, but let me show you how I'm going to make this smaller so I can go out to the internet and try and. Okay, for gracilis. Oh, this one. I like this one. So I would use this one. Remember, the adductors are also on the inner thigh, but on the very inner thigh is the gracilis. And I think when I double clicked it, it took it away. Oh no. So I would say name the muscle in red. How about gastrocnemius? So the gastrocnemius muscle, I would say name the muscle in this diagram. I could probably put a box over this one. Or I like this one better. I say name this muscle, I'd put a box. Or name the muscle coded in red. That would be your gastrocnemius. The gluteus. The gluteus medius muscle. Oh, it's in red again. Name the muscle in red. The masseter. This one, it's the only muscle in this diagram. So name this muscle. And then for the others, sartorius, this one is in red again here. So this one. But I think for the others, deltoids, I think what I did for most of the others is to use a torso. So muscle on anterior torso. This one is good. It's numbered, or do I like this one? Either one of these. This one is good. Number 1 would be the platysma. I'm sorry, that's number 4. Is it big enough? Number 4 would be I think it may be matching, but number 4 would be the platysma. Number 1 would be the sternocleidomastoid. 2, pectoralis. 5, deltoids. 6, serratus anterior. 3 is the rectus femoris. And then there was one with more. But I would just be able, because I do have a torso front and back, to try to get a lot of these muscles on it. Oh, your obliques, this is the one. And sometimes I may just put a sign up. Oh no, this is a video. I didn't want a video. Watch, it did say watch. But I would, this is how, I would just look over it to make sure you, oh, is this one the watch? Yep, that's the watch one again. This is a good one. And then I'll just put numbers on them. So you've got your pectoralis, serratus anterior. This one is even going down below. This will be my obliques external since I don't have them cut away. Serratus anterior. And then I would do the posterior muscles. I would also fit the did I have biceps? Yes, I would have had to fit the biceps. But here, where is there one with numbers on it? This is good. It doesn't have enough on it. But this one is the trapezius, deltoids, my triceps, my latissimus dorsi, my rhomboids. And that's a Quizlet. And so sternocleidoserratus, pectoralis, it looks like I had pectoralis major and minor on there. Because I wanted, it may be if you're matching, you'll have to be sure that you, I know I said you didn't have to know, you just had to know pectoralis, but I'm thinking now with both of these on there, the pectoralis major is the one I showed you in the diagram. I showed you serratus anterior, the obliques, rectus abdominis, teres major and minor. Minor is in the rotator cuff, the teres major. I'm not sure why it stopped. Oh, that's why. But this will be the teres major here. And the rhomboids. But I think that's all of them. Trapezius, yes, I showed you trapezius, lats, infra, supra, rhomboids, triceps, and deltoids. So these are the only ones that will probably be diagrammatic. So questions for me? Any questions? Please be sure to know that they are between 11 p.m. and I think 7 p.m. 7 a.m. Sunday, the internet, they're doing some type of work on the internet. Did y'all get that message?
Yeah, I did.
No, I didn't.
Yeah, I did not get that message either through email or anything else.
Yes, I'm glad.
I'm gonna stop my recording now then. Is that the
Absolutely.
end of it, right?
That's the end of it.